Welcome to Uromigos Live, an Unplugged 2024. All right. Third annual meeting. Thank you all for braving the elements to get here. Appreciate it. I'm going to go through just a few slides. I think a lot of you are aware of our partnership with Mashup Media and their Geo-Oncology Now product. It's been a great partnership for the last, gosh, I don't know. This is our third year of meeting, but probably going on our fourth year of partnership. So thanks to all those folks in the room, and a lot of work goes into organizing this meeting. So thanks to everyone for doing that. It's been a great partnership for us. We have a team here from Japan, our Uromigos Japan. Definitely, yeah. I love it. Those shirts will be on sale in the lobby after the show. They've done one podcast. It's sort of a little screenshot of the podcast. You can see the logo there, Yuji, Hiroshi, and Nobu. They've been great partners. Thank you for coming all this way. We told them we wanted them that they won the competition that I'm about to tell you about, and they made their flights within like 24 hours, right? So we appreciate your excitement and enthusiasm, and there's going to be more Japanese podcasts. Does anybody else speak Japanese in the room? No? Okay. Yeah. No, I figured. Yeah, I got you. But thank you all for coming. We also have the Trace Uromigos. Maria is here. Elena couldn't come, and Christina got stuck in Heathrow Airport. So Cristina Suarez Rodriguez is not here, but they are the Trace Uromigos. There is a Trace Uromigos Cup team. We've co-opted Laurence and Andrea for that team. So we've kind of put it together, but they've done, I don't know, maybe 4 or 5 podcasts in Spanish, maybe something like that are available, and we'll be doing more and doing some recaps of the meeting as our Japanese friends will as well. And the Trace Uromigos will also have a website soon. We do have our golden ticket winner. Woo-hoo. Where is she? Where's Demetra? I just saw her. Oh, there she is. Okay. So this is sort of Tom's brainchild, as you can probably tell. She was like spelling out Uromigos in some creative way, and she spelled it out with pasta. That's her winning post right there. So Demetra, welcome. Glad to have you here.
Brian, I think it's Greek pasta came all the way from Greece, I think, if I'm not mistaken.
Oh.
Yes. That makes it even more
definitely
special.
won that.
I didn't know there was Greek pasta.
Yeah.
That seems like an oxymoron. Greek pasta? Is that? Anyway,
Yeah,
thank you. Thanks to all the entrants.
Yeah.
And as I mentioned, we had actually an international Uromigos Cup competition. We had teams from Netherlands, Canada, Germany, and of course Japan. We had podcasts with each of them. And then based on number of listens of podcasts and the Twitter poll, which is on the right there, that's how Team Japan won and sort of earned their spot in the semifinal, which will be late today. But thanks to all the other teams. Kala was on Team Canada. Thanks to all the other teams for participating. They were good sports. And of course, thanks to all our corporate sponsors in the room. Obviously, we couldn't do this without you. We've had just great support from year one and a lot of enthusiasm to support us, and it means a lot to us. So thanks to all of you. We really appreciate it. All right, here's our agenda. So today is Bladder Cancer Day. We're going to do perioperative therapy in a minute here, and then go straight into ADCs. We'll take a small break. We have like a set change we've really upped our game in the Uromigos Cup this year, right? I don't want to brag, but we have a set change, and then we'll do our first semifinal, which is Team Japan versus Team Trace Uromigos. If you're posting about this, we'd love you to use the hashtag UromigosLive24, retweet, repost, whatever you want to call it. That'd be great. We'd love to stir some excitement up for this. And then tomorrow, we'll go over prostate and kidney cancer.
Monty's working out. Monty's not here. He's in Portsmouth, the UK. But he's going to. He might make an appearance. I'm not sure. But he is calculating. You can calculate your Twitter. You know about this, don't you?
I understand exactly what you're trying to say.
You know what I'm saying. I don't know what I'm saying, but you know what I'm saying.
Yeah.
And that's
he's working
important.
hard on Twitter and X with like metrics and, of course, supports Uromigos from there.
So you can work out the sort of top 10 Uromigos Twitter kind of following thing.
Yes, there will be prizes for the
That
top
went well.
Uromigos Live influencers.
Yes.
It'll probably be T-shirts, so just to give it away. So. And by the way, at the registration desk, there's like leftover T-shirts from Masco and leftover posters from War and Treaty last year. If you guys want those, just take them. They've been in my closet for a year, so please take them.
You've not made it sound very appealing, Brian.
No, they're clean. I'm just
Yeah,
saying.
okay.
I don't want them back, is what I'm saying.
Dusty.
Brian, the trophy looks pretty good, in good shape.
Oh, yeah.
Despite the
trophy,
trouble.
you can come up here and examine it during the break. It's in decent shape. I had to super glue these back on. There's some scuff marks. We have pictures later. It made its way to LA and then Seattle. There's some amazing pictures. I don't know if Tanya's here yet. Tanya, Petros, and Mani took some unbelievable pictures. I think Tanya won that competition. Like some unbelievable pictures.
Amazing pictures.
But come up and inspect. There's some scuff marks on the back, so it's traveled around the world, and we're looking forward to sending it on another tour. All right, and then without much further ado, what's our timeline?
56.
Okay. We have this first session, the perioperative therapy in bladder cancer, is going to be live streamed on uromigos.org. It's going to go smoothly. Dave McDermott's not in charge this year, so it's going to go smoothly this year. And I think we can just kick it off now.
Great. Do you want to start?
All right, I'm going to turn it over to Tom.
Excuse me. We'll try and start at 1 for the live stream for obvious reasons. If you miss the first 5 minutes, it makes it more complicated. Do you know when? Could you give me a signal when we're going live? Is that possible? Are we live right now? We are live right now. For those of you who are at home, welcome. We're a few minutes early. So we're not going to kick off till 1 because, for obvious reasons, if you miss the first 5 minutes, it's going to be like missing the first few minutes of an Agatha Christie. We're going to do that right now, Brian. I was going to do that. It's a good interruption, Brian.
He's just checking.
It's a good interruption. Shilpa, would you like to go first? Would you like to introduce yourself?
I'm Shilpa Gupta, medical oncologist at the Cleveland Clinic. Really honored to be here.
Kala, far away.
Sure. So Kala Sridhar, medical oncologist, Princess Margaret Cancer Center. Also super happy to be here.
Andrea.
Andrea Apolo, medical oncologist in Bethesda, Maryland, at an unnamed institute.
Great to see you all. Petros Grivas. I'm a medical oncologist in Seattle, University of Washington and Fred Hutch Cancer Center. This is my third in a row Uromigos meeting, and I'm very excited about it. Great to be here.
That was my introduction slide. Okay, so I'm going to talk a little bit. We're not going to have very many slides. We've got maybe half a dozen slides, maybe a few more. I've made them myself. They're mainly accurate, I think. I've tried very hard, but some of them are quite difficult. We're going to start by talking about Niagara, and then we're going to move on from Niagara. We're going to talk about adjuvant trials. We're then going to talk about other neoadjuvant trials. And then from there, we're going to talk about we've got a couple of votes. Oh, we didn't talk about that. There are some votes coming up, and I think it's with a QR code. So you take the picture of the QR code, you then vote, then that will come up. The voting in this section, I think, is towards the end, about 3/4 of the way through. And then at the end, we're going to talk about bladder-sparing approaches, and we're also going to talk about what might happen if the ADCs have positive trials in this space. So the Niagara trial was a study which we explored the combination of durvalumab with GemCis in the neoadjuvant space, but we also had the adjuvant period as well, 8 adjuvant cycles, making a total of a year of durvalumab therapy. We compared it to 4 cycles of GemCis, standard treatment. We allowed split-dose GemCis, and a significant proportion of patients did get split dose. That allowed us to go down to a creatinine clearance of 40 rather than the traditional 60. The primary analysis was 1,000 patients. It was the ITT population. The study itself was run globally over 200 sites around the world. It started enrolling before nivolumab was approved, so it didn't have nivolumab as part of the control arm, and that's almost no patients had adjuvant nivolumab in the study. More contemporary trials, I think, will be different from that. It allowed different histological subtypes, providing there was a component of urothelial cancer. Obviously, patients needed to be fit for radical cystectomy. One of the surprising things from my perspective about this trial was the large proportion of patients who went on to get radical cystectomy. It was an open label trial, and about 85% of patients in both arms had radical cystectomy. Indeed, a few more patients in the durvalumab arm had cystectomy than in the study arm. And there's debate about why that might be the case. Petros, in his discussion, talked more about the detail of these surgical patients. The data set's relatively immature. We haven't been through all of the detail, but I can tell you, and it was in the New England Journal paper, that the commonest reason for not having cystectomy was patient choice, and then behind there was doctor's choice. I wonder, with hindsight, if we need to write our CRFs more clearly in the future. I'm not sure our CRFs are always fantastic. And that also applies to subsequent therapies, not just in this studies, but in other trials as well. I think when patients come off study, we tend to be much more lax about the detail that we report. But when we do report it, everyone thinks it's a randomized phase 3 and that data must be golden and absolutely correct. And so I think that even with the context of a randomized phase 3, some of the data we use can be improved. I actually think that also applies to adverse events. At the session in ESMO this year, the discussant for the breast cancer plenary session described CTC criteria for chemotherapy. And if you look at this trial as well, there's no real difference in adverse events between the two arms, but we all know that immune therapy is associated with life-changing toxicity. And we haven't really got our head around how to measure life-changing toxicity, and indeed, we haven't got our head around measuring quality of life. In the maintenance of durvalumab trial, there was no difference in quality of life between the two groups, but we all know that coming to hospital every 2 weeks and having an injection with a 10% chance of life-changing toxicity does have an effect on quality of life. So within the context of this trial, some of the data points, in all the trials we do, some of the data points are really accurate and very robust. Others we need to put in the context of what we know. The study itself had 2 co-primary endpoints. The first was pathological complete response. Pathological complete response read out 6 months initially after the primary analysis. And that showed a difference between the two arms that wasn't statistically significant. That was because a very low amount of alpha was allocated, but also 59 patients weren't allocated correctly because the analysis was done prematurely. And that was a programming issue. And actually the analysis here is the correct analysis for all of the patients. I'm going to talk a lot about PathCR today. And I've spent a lot of time on this issue over the last 2 or 3 days. And I've read maybe 20 different studies looking at PathCR. And I can tell you it's extremely confusing. People report PathCR very differently. Some people use only the surgical patients, some use all the ITT patients. Some studies are broadcast prematurely, where not everyone's got to have the opportunity to have the surgery. And in other studies, radiotherapy was given as an option, and some people in those studies use clinical CR as PathCR also. It's also true that some people think TIS, in situ cancer, is PathCR. We did that in Abacus, by the way. And other people don't accept that as PathCR. So I really warn with caution when we start doing PathCR cross-trial comparisons. The final piece is there's huge variability in the T2, the clinical T2 stage. One of the things that we forget is in the adjuvant setting, we have the pathology in the pot, and we know what the T and the end stage is accurately. In the neoadjuvant setting, we try and combine CT radiology with pathology to come up with a clinical stage, and I don't think that's particularly accurate, to be honest. So again, we're comparing T3, T4 with T2. I'm not sure that's particularly accurate. But here, these are the most robust analysis we have. It's the ITT population. Everyone was included. It's a 1,000-patient study, and it was centrally assessed. And this is probably the reality of GemCis and GemCis durvalumab, and I suspect this becomes a new benchmark, although we as a group can have that debate in a second. Event-free survival is different from disease-free survival. Disease-free survival is assessed in the adjuvant setting. In the neoadjuvant setting, we count surgery as an event. And that brings its own level of complexity, because patients don't have surgery for different reasons. And indeed, some of the winners don't have surgery. And I'm quite worried about the EV-Pembro and EV-Durva-Tremi trials. There was a SURE trial recently, neoadjuvant sacituzumab govitecan, where the last 7 patients in a row opted for radiotherapy rather than surgery. Now, strictly speaking, they're going to be in the ITT population, and that means they're going to have a low PathCR rate. We as a group need to have a discussion about how we're going to assess that.
So Tom, if I could interrupt you, I don't think it's
That was a nice
just
interruption.
pathologic. It's not just pathologic response rate. event-free survival, disease-free survival also vary within trials. And we saw that in the Ambassador trial versus the Checkmate 274 study, in that the definition was not exactly the same. So we actually had a workshop that we got together with the FDA, and we talked about this because there was so many variable differences as to what you count as an event. Do you count a TA coming back in the bladder in somebody that had an upper tract disease as an event, or do you just kind of scrape it out and not count it as an event? So that's just one example, but there's variabilities in general, not just in pathologic complete response rate, which is huge. And I think there needs to be a consensus in order for us to design the best trials with comparable outcomes, but also in disease-free survival and event-free survival, which right now they're not.
Andrea, if you have local relapse, and I think the BCL 2000 in the adjuvant setting, how does the FDA think we should account for?
So this was an interesting point because there was a panel, there was the FDA, and we discussed what local relapse would count. So if it was a muscle invasive local relapse, yes, of course, then that is considered an event. If it was something that could be managed with a TURBT, with a scraping, with or without BCG, then that may or may not be counted as an event. And the panel was split. And of course, we were an even number. So, so we basically just wrote it up as saying you may or may not, but you have to define that in the beginning, and you have to let people know what you're counting. And for the Ambassador study, we did not count local recurrences that could be scraped out as events, which is different than the Checkmate 274. And you may say that that's not right, and some people say that that makes sense because it's not a metastatic recurrence and you can treat it locally, but I think it's up for debate. So I just think that we just need to have a consensus.
I'm going to keep going with that. So event-free survival was statistically significant, and so was overall survival. You can see the absolute differences there. There was a phase 2 study in purple here. This is one of my slides. You can see that. I've got a series of slides. And the phase 2 study out of Switzerland is actually the only other perioperative study. Most of the other neoadjuvant trials we've done have been purely neoadjuvant. Doing investigator-initiated perioperative studies is much harder than doing investigator-initiated neoadjuvant studies because you've got to give them the patients that adjuvant period of therapy as well. So it's a lot more expensive, and for universities it's more difficult. But the Swiss did do that, and actually they show quite similar results, as you can see here. So Shilpa, Petros, you did the discussion, so you're going to go last. Shilpa, what do you think about the results of Niagara, and what are the strengths, and what are the weaknesses? And then, Kala, I'm going to ask you after that about what you think we need to do next and what we haven't seen so far.
Yeah, I think congratulations on the Niagara trial to everybody who conducted it. I think it's a phase 3 level 1 evidence, large trial, 1,000-patient trial, clearly shows overall survival, event-free survival benefit of GemCis Durva. I especially like the fact that it was more inclusive than a lot of other trials, that N1 patients were included. Creatinine clearance was in the traditional Galsky criteria, but what we really use in the real world, 40 was the cutoff instead of 60. So I think all those were really great to see. And I think it also points out to the fact that PCR is not the ultimate endpoint, and we have to see the durability of the response and the overall survival. And we've never seen such data before. So I think it also highlights that patients who got downstaging to T1 or lower also derive benefit. With the advent of immunotherapy in this space, we need to move away from just PCR because of the nuances you mentioned, and look at what the event-free survival and the overall survival is. I think the only weakness, I would say, is that we have not really teased out the neoadjuvant versus adjuvant portion of these immunotherapies, and FDA is now mandating us to think about that, just like in lung cancer trials. And for example, if somebody gets PT0 with neoadjuvant treatment of Durva GemCis, do we really need to continue adjuvant, and for how long? I think those are the questions we need to answer.
And if they don't respond,
do
you continue adjuvant treatment in somebody who didn't respond
so
at all?
We really need a trial like the melanoma folks have done, where we are looking at adjuvant versus neoadjuvant portions.
I agree with Shilpa. I love how forward-thinking this was and that it included a lower GFR. I really like that with the split dose. It's something that we do in practice. It's really nice to have a trial here. It would be important to know how those patients did. So that's really important. And in the N1 disease, I was a little confused as why there was only 5% of the patients that had N1 disease.
We amended the protocol. We allowed
That's what
them
I
in
figured,
towards the end,
yeah.
number one. And number two is it was surprising. We amended quite early, and I was expecting there to be many more patients. And I don't know how you feel when you're looking at radiology with patients and they've got nodal disease. I think many surgeons now are a bit anxious about putting them through a big operation. We kind of are here. Petros, what's your thought on that?
First of all, I agree with all the points made, and I think to your point, it's very difficult sometimes in the ECRF to capture accurately N0 version 1. We have these scenarios,
It's like
these
a
gray
fuzzy
zones,
node that you're not
exactly,
really
fuzzy
sure
nodes
what
that
it
Andrea
is, right,
mentions,
right.
which is like 9 millimeters or 10 millimeters. We don't bother to biopsy sometimes because we start with neoadjuvant chemotherapy and see what happens. So I am wondering whether this 5% may be actually be higher. We just didn't capture it. But I
think the
agree.
cutoff was 2 centimeters, right?
How was that defined, Tom, the N1? Because other trials define it, not the RECIST measurable, but like 1.
1.5,
1.5
right.
or-
I think this was 2.
There was
yeah.
a 2 centimeter
Yeah.
limit with that. Yeah.
Which,
Probably that's why you did
In
it.
shortest axis, yeah.
exactly, as Andrea points out, the short axis, some people use 1.5 centimeters in the short axis, and I'm sure that many people did not get a biopsy, which is not the routine practice for all.
Right.
So you might potentially have had a higher proportion. But I think overall in clinical practice, we tend to approach the N1, the single perivesical node patients, usually similar to an N0. So I liked that I saw that in the Niagara trial. The other point, if I can just comment too, I was very happy to see that divergent histology. I know you have an interest, Andrea, with ICONIC trial, were included, and I think it was 15%, Tom. About half of them were squamous histologies,
Yeah.
and the other was a mix. It was good to see that, and if I remember correctly, it was not mandatory to have predominance
Yeah,
of
no
urothelial,
predominance.
as long as you have a primary urothelial histology.
Carla, what was your take when you saw this? Firstly, do you think it's practice changing? Do you think it's broadly practice changing? And then what are the concerns? What do you still need to see from this data set that we haven't seen so far?
Yeah, so I echo the congratulations. I think it's the first trial in the neoadjuvant setting. I think it shows that we can actually do trials in this setting. And, fortunately it was a positive trial, which always adds to the enthusiasm and excitement. So I think I was really happy about that. All the points that were mentioned, I like the fact that it allowed a creatinine clearance that was a bit lower, split dose, which of course is something that we've done a lot of and looked at. And I think it's so much easier for our patients. It's a nice way to give platinum-based chemotherapy. I like that. In terms of node-positive disease, I think this is defining itself almost as its own entity. Like it's sort of not quite MIBC, not quite metastatic disease. So I love the fact that we're including it because it's practical. Admittedly, you may not be picking up all the node positivity with CT scans, right? Because they're very dependent on size. There may be normal-sized lymph nodes that actually might have tumor cells within it. So I think all in all, I like the study. I like the fact we got it done. I think the results are encouraging and interesting. A lot of questions remain unanswered, and I think we'll answer that over time. One of the areas that I'm particularly interested in, what about the patients who didn't get surgery? Did they get bladder sparing? Did they get trimodality therapy? And what are their long-term outcomes? We have seen propensity analyses showing that patients who get radical cystectomy and trimodality therapy who are appropriately selected have similar outcomes. Sometimes even TMT does a little better. What's happening in that patient population? And you mentioned the SURE study earlier. Patients who have a complete response don't necessarily want to lose their bladder. And I think we need to listen to that. And we need to think about designing trials like this, but are somewhat agnostic or open-minded to what happens locally. Because often we're in a situation where you get this really great neoadjuvant regimen, maybe something like EV Pembro, but then you're mandating a cystectomy, and is that really appropriate or patient-friendly?